Welcome everyone. I'm gonna go ahead and get started. My name is Luma Bonilla Webster. I'm the programs manager for the Illinois chapter of the American Foundation for Suicide Prevention. Thank you for joining us today. This is part of our Research Connection series, which we do twice a year in the spring and in the fall. Again, some of our information is displayed on the screen. You can email us at illinois@afsp.org or check out our website with information about our chapter at afsp.org/Illinois. Reminder that today's presentation will be or is being recorded, and we will be uploading it to our YouTube channel. So if you wanted to find it there, the link is on the slide. We'll also add it into the comments later, so you can just copy paste and save it for another time. If you would like, because of the presentation today is being recorded and you don't want your name to be shared, again, we try not to share attendees' names as part of the recording, but feel free to rename yourself if that will make you feel more comfortable. And then a little bit more about us. We're the American Foundation for Suicide Prevention. Our mission is to save lives and bring hope to those affected by suicide. And we do that in a couple different ways. One, by funding scientific research. We are the largest private funder of suicide prevention research in the country. We also do a lot in the education spectrum. We take that research and create educational programs for the community about mental health, about suicide prevention, and about suicide loss. And then we do advocacy for public policies that support mental health and suicide. And we do offer support for survivors of suicide loss and those who are affected by suicide. So if you want to learn a bit more about the American Foundation for Suicide Prevention, you can go to our website at afsp.org. And we are the Illinois chapter. We cover the whole state. And I'm going to stop here and then transition over to Meg, who is, actually, I'll let her share. Go ahead.
Hi, my name is Meg Graff. I have been the Research Connection Coordinator for 14 years, I believe. I'm really excited to bring this program. It brings so much hope to see the new information we have and how we can apply it to prevent suicides and help those with mental health disorders. I'm very excited about how our chapter is able to deliver things like this for free. And are able to do that because of fundraising during our walks in the fall. So please look at the website Luma shared and join us for a walk. And lastly, I'm really thankful that Dr. Steele Smith is able to join us today. We do serve the entire chapter, and I think it's really important that we're able to show the rest of the entire state how much we support them. And I'm hopeful that this presentation will give better tools to those down south. I'd like to introduce Dr. Steele Smith from the Nationwide Children's Hospital and Ohio State University. She's going to present for us on individual and contextual level correlates of suicide in rural areas of the U.S. If you have a question, pop it in the Q&A box and we'll cycle through those at the end. Thank you.
All right. Thank you for having me. Thank you to Megan Luma for organizing this. I'm pulling up my slides now, so just give me a second. Okay, so this is going to be my topic. I kind of shortened the title here just for everybody. Talking about suicide in rural counties of the United States. Just some basic information at first, some disclosures that this is some protected data. I use some protected data through the Census Bureau, and this project was actually funded partially by the American Foundation for Suicide Prevention and a postdoctoral scholarship fund. So general outline, first just talk a little bit more about the rural context, like why rural suicide, why are we interested in, what is it about the context of these areas that we would want to study suicide that is specific to rural. Then I'll go into the methodology that I used for the analyses that I did, along with study findings and kind of what we can learn from that in general. So first, why rural suicide? If you're not familiar, the suicide rates tend to be higher in rural areas than urban areas, kind of across the board, and looking at it multiple different ways. They also tend to be increasing more rapidly in rural areas compared to urban areas. And this is data here on this slide is, a little bit dated. It's from 2016, but this study kind of looked at the most rural areas. So these are counties that have a population of fewer than 2,500 people at the main center. And you can see the suicide rate went from 18.3 up to 25.0 per 100,000 people. And these rates have continued to climb. And these rates showed the most drastic increase compared to any other county. So compared to like your largest cities, your small cities, even like your small towns. And just to kind of represent that visually as well, this slide shows suicide rates for metro counties compared to non-metro counties. So metro counties are going to be any county that's like big cities, even small cities. And then non-metro does include like small towns and your most rural areas. It's kind of a combination. And you see here, the red line across the top is these non-metro areas, which I'll refer to as rural as well, even though they do include some of the smaller towns that don't always get classified as rural. But that non-metro line, back in 2007, the suicide rate was 16.1, and that's increased to 23.3, whereas the urban rates are also increasing, but not as much. So we see the non-metro jumps about 44%, where it only increases by about 22% for the more urban metro areas. And this results in gaps in suicide rates. So it started at about 1.25 higher for rural areas and ended up being 1.5 times higher in your more rural areas compared to the metro cities. And even just looking a little more closely to your state of Illinois, these are the similar trends. So you don't have as many rural counties or these non-metro counties, so the rate's a little less stable. So you can see that in that red line across the top. It kind of fluctuates a bit more, but it is consistently higher than the metro area. It's also increasing more rapidly. So you see generally that the non-metro increased by about 67%, whereas the more metro, rural area, or urban areas increased by about 33%. And the gap, there's still a gap here from about 1.3 up to 1.6 in the most recent data that's available. And this is for all, basically across the lifespan, so all ages 10 and up. Next, I just want to show a couple graphs that are again from this older article, but look at some of the breakdowns. So this is by most deprived. So it's looking at large metro, small metro, micropolitan areas, and rural areas. That's what the 4 lines represent. And that rural is the brown, the one on top. And these are among the most deprived. So this is like an economic deprivation area where there's going to be high poverty, high unemployment, low wages, instability in housing, things like that. So the counties that fall into that classification, you see this breakdown that rural is just higher suicide rates compared to all the other types. And similarly, this is looking at just large metro compared to rural, but then we have large metro with low deprivation and high deprivation, and rural with low deprivation and high deprivation. And again, this deprivation is that socioeconomic, housing instability, kind of just poor communities in general. And you see here, again, rural, that top brown line is the high deprivation counties. And you see the red line is actually the rural low deprivation. So back around the year 2000, they actually had lower rates of suicide in these rural areas that were doing well economically, financially, things like that. But we've seen that rate drastically increase to be higher than the metro areas, even though it's not really a deprived area, it's a well-off area, but suicide rates are increasing. And so more just about the context of rural areas. So why might this be? Why might these areas like have higher suicide rates? And these are just different risk factors for suicide that are particularly um, that particularly impact rural residents and the people living in these communities. So things like social isolation, being a little more secluded from people, living, miles apart from one another, not having as many opportunities in those areas, and that can be related to healthcare, not having access to services that may be needed in a timely manner. Similar for education and employment, having to travel farther or having to leave the area to access better opportunities, whether it's education or employment. There's also the issue of lethal means accessibility. And so lethal means, in case you're not familiar with that term, that's just availability or ways to harm oneself or die by suicide that are more likely to result in death. So we're typically talking about like firearms is what you typically hear about with lethal means. But there are other things that are also more likely to result in death that are maybe more accessible in these rural communities or more readily available just within homes. There's also a lot of stigma and that's been changing. We're trying to improve stigma, I think, across the nation, and we're doing a good job. But oftentimes, rural areas still have a lot of the stigma about reaching out for help or letting others know when they're struggling. So that's a common risk factor in rural areas. And then tying in with that deprivation that I talked about, low income, high poverty, uh, many rural counties are persistently in poverty, and a lot of that has to do with lack of opportunity, lack of employment with higher wages and things like that. So now I'll give you just a general overview of some of the methods I did for the analyses piece that I'm going to run through for this. So what I did was a retrospective case control study. I included participants age 10 and older, so it's across the lifespan, but I'm only looking at non-metro counties of the US. And this RUC 4 to 9, so the RUC is the Rural Urban Classification Codes. And those are a set of codes used to classify county types. So 4 through 9 are like your non-metro. So it can be small towns up to your like frontier, most rural counties. And then this is data included 2007 through 2019. My cases are those who died by suicide based on death certificate data. And my controls were anyone who completed the American Community Survey in the same time period, again, for these non-metro counties within the US. Measures that I used, so individual variables were somewhat limited based on availability within death certificate data because that's where the cases came from. So it included age, sex, race and ethnicity, and then the marital status. I also used several county level variables, and this was where the majority of my variables came from. So these first three here are indices that I put together. So area deprivation is like what I was talking about previously that has to do with socioeconomic status. It has to do with housing, availability of like a telephone or cars in the household, level of education in that area. So it's like a combination variable that accounts for multiple things like that. Social fragmentation index looks at basically how fragmented the society is, and that's a combination of variables related to like living alone, moving recently, having um, divorced or single individuals living in that community. And then the social capital index puts together a combination of what's kind of available in that community to engage people. So it includes civic organizations, businesses, clubs, recreational opportunities. It's kind of a combination of things that are available for people to gather together within that county. There are also several health service variables that I included in the analysis. So different types of health facilities that were there, the ratio of primary care providers, psychiatrists, rates of health insurance. And then also these additional county variables, so like internet availability, so that's for high-speed internet within residential homes, how common it was, the type of economy that is within that county, particularly looking at farming and mining for those more rural counties, rates of drinking establishments, gun shops, just to kind of control for some of these issues that can drive suicide rates. So religious congregations, overdose, veterans, and then just general demographics related to the county, like the general age and racial makeup of the counties. So this is the general sample that I use. So just first to preface this, results are rounded based on guidelines from the US Census. I mentioned that was kind of protected data. So that's why you see some of um, these rounding issues. It wasn't nice and neat with all these zeros, actually. So this table provides just the demographic information, so these individual level characteristics of the people who were included in the sample. The first couple columns are the controls, which are those who did not die by suicide, followed by the cases, or those who did die by suicide. You can kind of just see some differences between the groups, like the racial makeup overall. The majority of the sample is white. However, controls tended to be slightly more Black. There's a slightly higher percentage of non-Hispanic Black individuals. The others are fairly similar across the board. And then you see the age makeup, where for the suicide decedents, the vast majority of those cases were in the 25 to 64 age range, and fewer were in the younger and older groups. And of course, when it comes to suicide for sex, the vast majority of suicide decedents were male, about 4-to-1 to females, whereas the control population was more evenly distributed. And then marital status, mostly that married group is actually lower for the suicide cases than the controls. And divorce is slightly higher for cases compared to controls. Just some other basic information about the cases themselves. So firearm suicides across this time period made up over 63,000 deaths. That was the vast majority, followed by hanging, suffocation, and then other methods. And there were roughly 7,200 suicide deaths in 2007, and that increased by about 1,500 up to 8,700 deaths in 2019. So like the trends I've shown, like that number has been increasing across this time period. So this is going to be what I'm going to show a lot of from here on out are these forest plots of the different odds ratios that we did. So did some logistic regression on these, and these are odds ratios and 95% confidence intervals. So all the green diamonds are your odds ratios, and they all do have confidence intervals in those black brackets around them. Some of them are hard to see because they're so small, but they are there. And the first analysis I'll discuss is the overall suicide rate. So I included everybody in that sample of that table I was just showing you, and just looked at these different factors that I mentioned to see what's significant, what's not, what are some differences that stand out about these rural counties that have really high rates, what's going on with some of those. So you see here, so how you read this basically is the line going up and down is the odds ratio. So anything that's 1 or crosses that 1 line is not significant. And then anything to the right of that line is associated with increased risk of suicide, and anything to the left is a decreased risk of suicide. And you can see here down the side, all the variables compared to a reference category. So for the top 4 rows, the reference category is the non-Hispanic white group, which is the largest group in the sample. And you see that all of these racial and ethnic groups have a lower odds of suicide than the non-Hispanic white group. When it comes to males versus females, males have a much higher odds of suicide, or an increased risk of suicide compared to females. And then the young and old, it's lower odds of suicide compared to the middle-aged group. And then for married is lower, but widowed and divorced are actually higher rates of suicide compared to the never married groups. And so this is just additional variables, that same overall sample that you can see. And these are more of the county level variables that were somewhat significant. So just a reminder that line 1 is where whether or not it's significant, anything to the right is increased risk of suicide, anything to the left is decreased risk of suicide. And then you have your variables down on the far left over here in the different rows compared to a reference category. And on this page in particular, a couple ones I just wanted to point out. So internet availability, and this again has to do with like residential homes having access to high-speed internet. So for the moderate to high, so that's kind of like the middle half compared to low or lack of internet availability in the homes are associated with decreased risk of suicide, whereas counties that have, or individuals living in counties with higher internet availability, it's actually no different compared to the lower. And then another thing I wanted to point out is social capital. So this is opportunities to engage within the community through different types of groups and organizations is actually associated with a decreased risk of suicide. So the more social capital a county has, basically the lower the risk of suicide. Those two things are associated. You can see some of the other things that were associated related to increased or decreased risk here across the entire population of all rural residents. The next thing I want to take a little time to look at is method of suicide. And so these are the 3 general methods we looked at. So firearms, hanging, and other. And these are the actual suicide rates among rural areas. So firearms is the highest, followed by hanging, suffocation, and then other. And so same idea here. This is a similar forest plot. It looks a little different because it's one model that looks at firearm, hanging, and other kind of simultaneously. So that one in the middle is whether or not it's significant. Everything to the right is increased risk. Everything to the left is decreased risk. And here we just, for each of the variables or each of the comparisons, we have a diamond for firearm, hanging, and other. So the black is for firearm, blue is for hanging, and then the yellowish color is the other methods of suicide. And again, just a couple things to highlight here. We can kind of compare these odds ratios and see what's different or what's similar across the different methods. But we see here that among comparing divorced versus the never married, they're all these divorced individuals are at increased risk of death, of suicide death by each of these methods. However, we do see that hanging is maybe a little less common than the other 2 methods among divorced individuals. And then when you look at widowed versus never married, death by firearm suicide, there's an increased risk of death by firearm suicide among widowed, where there's actually a decreased risk of death by hanging among widowed individuals. So that kind of starts to separate out some differences here. Another thing to point out that's kind of an obvious difference is those 65 and over. So they have a decreased risk of suicide, of death by suicide using hanging and other, but the firearm deaths are actually no different from this middle age group. So again, it kind of starts to separate it out. And the other area or variables you see this separation is among the different racial and ethnic groups, whereas compared to your non-Hispanic white group, some of these racial and ethnic minority groups show some differences by the rates of suicide or the different associations with suicide here. So specifically the hanging suicides, these individuals who are, and I don't think I mentioned this before, that first one is Asian, Pacific Islander, Native Hawaiian, that group, compared to the non-Hispanic Black, you see the hanging, they have an increased risk of suicide by hanging, whereas firearm and other is at decreased risk. Same for your American Indian, Native Alaskan group. So that's increased risk for hanging suicide, but decreased risk for firearm or other suicides compared to the white groups. And then Hispanic, you see the same kind of trends there. And then again, kind of similar, so it's a similar chart to look at and to read, just with some of the more county level variables rather than those individual variables, and how these differences might pan out by method of suicide. And the only thing I really wanted to point out here was this social fragmentation. So this was one of the few models where this variable is actually significant, and you start to see some differences here. So again, social fragmentation was related to uh, like living alone, recently moving, being divorced. So kind of a fragmented society. So counties that have higher levels of social fragmentation compared to low, you start to see some differences in the increased risk by method of suicide. So other and hanging are at increased risk, whereas the firearm tends to be no significant differences across this social fragmentation variable. Okay. So now I'm going to move on and do some quick just synopsis over the different demographic categories that I broke this down by. So far, the first few graphs were looking at the overall uh, sample, and then we broke it down by method of suicide. And now I'm going to look specifically at race and ethnicity. So this is going to be some stratified analyses within each of these specific groups, and just how I'm going to discuss basically how they maybe differ from the overall findings. And this again is just the different suicide rates for the different categories that were looked at in these analyses for this different period. So you do see that the American Indian, Alaska Native has the highest rates, followed by the non-Hispanic whites, and then the Asian Pacific Islanders, followed by Hispanic, and then non-Hispanic Black. So just generally, just a quick summary for the non-Hispanic white group, it basically accounts for 90% of the suicides, 85% of the population. So it's not really different from the overall findings. This is basically the group that's driving those overall findings. Next, for the non-Hispanic Black, so this is a smaller group in population size. There weren't very many things that differed. There were fewer variables that were significant in the model specific for this group. And one of those differences was that married individuals were not significantly different from never married, whereas in the overall sample, they had a decreased risk of suicide. And then the majority of contextual factors were not significant, so I wasn't able to really piece out differences for this group. Among rural Hispanic populations, again, smaller population, not as many things were significant, but this one variable, social fragmentation, did kind of pop out. So I just wanted to highlight that here. And you see that, again, this was kind of what we saw with the hanging suffocation, I believe it was, among the methods, that there's this increased risk of suicide among this high socially fragmented group. So the more fragmented the community, the greater increase for risk for suicide among the Hispanic population in rural communities. And then American Indian, Alaska Native, differences in marital status that weren't seen elsewhere were kind of highlighted here. And that's what I just wanted to highlight. Again, most other variables were not significant or didn't really change, but there was some change here. Among this population, the widowed group, in all other models, I'm pretty sure that the widow had increased risk of suicide. However, here, specifically among American Indian Alaska Native group, widows were at decreased risk of suicide compared to those who had never been married. And the divorced group was even not significant, whereas in other models, they were at increased risk of suicide. And then lastly, for this, again, this is the Asian Pacific Islander Native Hawaiian group, smaller sample size, so not as many things were significant. But again, marital status did kind of pop out. And of course, here you see a lot wider confidence intervals, and that's due to the smaller sample size. But there's no difference basically here between divorced, widowed, and never married. Only that married group is still at a decreased risk of suicide compared to the never married. So next I'm going to look at sex separately. And again, I highlighted this earlier, but about 80% of the suicides in rural areas were males. Suicide rates vary drastically between males and females. We see that here. So one thing I just wanted to compare between these two models, when we looked at males specifically, so this is the top portion, same with odds ratios and everything. So everything to the right is at increased risk, everything to the left is at decreased risk. The top three are related to males, the bottom three in green are related to females. And you can kind of see a difference here, particularly among the widowed individuals again. So among males, those who are widowed compared to those who are never married are at increased risk for suicide. And then for females, those who are widowed are actually at a slight decreased risk for suicide. It's just hovering, that confidence interval is like right at the 1. So maybe not significantly different, but tending towards that decreased risk of suicide. Oh, yeah. And then, so that's all, those are the main differences by sex. Next, I just wanted to do a breakdown by age. So the 3 age groups I used here were young, middle-aged, and older populations. And again, middle age makes up the majority of this sample, but you can see the different rates of suicide. So the younger group does have the lowest rate of suicide, followed by that middle, and then the older age group. And first, I just want to do this breakdown, the same breakdown you've seen already for older rural adults. And the main thing I want to highlight, so again, same kind of thing with that line is at the 1, but I wanted to highlight this, males versus females, simply because this is the highest odds ratio that I got from any of the analyses, just emphasizing the just the increased risk for males in this older population, so 65 and over. It's the odds ratio was 10.9, so that's just like 10 times the risk for males than females for death by suicide in these rural communities. And that's just, so it's just a very large effect size that we see here. Among the different contextual variables, wanted to highlight 2 here. So first, social capital. And again, social capital has been significant in some things, not on others, but here it really stands out so that the more opportunities for people to engage through different organizations, recreation, and just different clubs meeting in the county, that is associated with a decreased risk of suicide for older adults in rural communities. And similarly, so almost like the opposite, social fragmentation. So the more fragmented the society is, people moving a lot, living alone, divorced, there's an increased risk of suicide in these communities that have higher levels of this social fragmentation compared to lower levels. And then, so for the next kind of age group, this middle to aged group, it was the majority of suicides. So you kind of see the same general overall trends that we saw for the overall model: divorced and widowed, increased risk; married, lower, decreased risk. Males have this increased risk, but it's only about 3.5 or so times higher, not like that 10 that we saw among older adults. And then the racial, ethnic, different groups are all lower risk of suicide than the white group. So next, I have a few additional slides on rural or on youth in particular, because now I work at a children's hospital now, so focus has shifted a little bit more towards youth suicide. So this is ages 10 through 17 from 2017 to 2021. And just the different rates comparing this rural and urban. And again, this is like the metro, non-metro. So blue are your non-metro rural communities, looking at the suicide rates. And across the board, they tend to be higher for youth, even if you break it down by males, females, or by type of suicide method, it's always higher in the rural than in the urban areas. And then this is also a breakdown by race, ethnicity, where you see these suicide rates are higher, tend to be higher in the rural communities, with the exception of non-Hispanic Black, where it's fairly similar across the 2 communities. But otherwise, youth suicide rates tend to be higher in rural areas. And then just to put this slide in here, the same kind of idea of tracking these over time. suicide rates are increasing among youth. You see what they start as and what they move up to. And again, 112% increase in your metro, more urban areas, and 142% increase in non-metro rural counties. And again, just this increasing divide between the non-metro and metro communities among youth suicide. And this is across the nation, 10 to 17. So just looking again at young persons in rural areas, these are the those more individual level variables that were examined in the model. One thing to point out that kind of differs here is married versus never married. So this population is 10 to 24. So the vast majority are never married, and even fewer are divorced and widowed, which is why you see, again, those really wide confidence intervals around the blue diamonds. But we do see this stand out. This is a little bit different, where this married versus never married is actually at increased risk of suicide, whereas in all the other models, married was either not significant or there was a decreased risk of suicide. But for this younger group that is married, there's actually an increased risk of suicide. You also see this start to pop out here, that this American Indian, Native Alaskan group compared to the non-Hispanic white group are actually at increased risk of suicide for this younger population. Whereas when we look at, ages across all ages, they were at a decreased risk. But among youth, they have an increased risk of suicide compared to non-Hispanic white youth in rural areas. And then among contextual variables, just a couple I wanted to highlight here. Social fragmentation. Again, this is another time where this variable was significant. And so for youth in particular, the more fragmented a society, so people living alone or divorced, moving recently, the higher that is within a community, there's an increased risk of suicide among these younger individuals in those counties. And you still see the social capital opportunities to engage. That is still a decreased risk of suicide for this younger population. And this just kind of summarizes that. There's some racial differences that were seen among rural youth that weren't seen elsewhere, and then those marital status differences that were highlighted, and then specifically that social fragmentation variable. So just kind of to summarize and discuss what does this really tell us, or what can we really learn from this? So it helps to identify some groups that can be targeted for prevention or intervention efforts within these rural counties specifically. So it kind of highlights where some of the greater need is, where some of the greater risk is, and some of these factors that can be modified or adjusted. So specifically just that, looking at those young adults who are divorced or widowed or even potentially married, like knowing that that was an at-risk group that had higher rates of suicide compared to those who were never married, that can be a targeted group for some early prevention intervention efforts. Similarly, the American Indian, Alaskan Native populations, or even Asian individuals just in rural areas in general, those were where we saw some differences in rural areas, especially again among the youth, that they were kind of at increased risk of suicide. And back to that method slide, they were especially at increased risk for the hanging and suffocation suicide. So knowing how to target and maybe deliver some prevention efforts within these specific groups can be really helpful pulling out of this analysis. And of course, that those elderly males, where I mentioned it was like 10 times higher than elderly females, and it was also a lot of it is driven by firearm access, or firearm suicide deaths. That is another area for intervention efforts. And then so that's people groups that specifically can be targeted. There's also different intervention strategies that could help specifically within rural areas. So one being connectedness. So this is again those kind of addresses both social capital and social fragmentation. So trying to build connections, collaborations within counties, within smaller communities where people can engage with one another and feel welcome. That can potentially be a intervention strategy. And this variable in particular stood out or was significant for Hispanic individuals, for the older group and the younger group, all living within these rural communities. So these are groups that might specifically really benefit from increased connectedness. So protective environments, lethal means restrictions. We see that like the leading suicide cause of death in rural areas is firearms. So of course, encouraging restriction to firearms, especially among the elderly, and then especially limiting or reducing opportunities for the hanging suffocation within the different minoritized racial groups, and doing some of that can uh, help reduce risk of suicide, specifically in these rural areas. And then some other things like economic supports, increased opportunities, so work opportunities, education opportunities, even increasing access to healthcare services. So this study did end in 2019. So one thing I wasn't really looking at the time for that time range was like telehealth, but that has definitely increased, especially getting access to individuals in more rural communities, getting them access to healthcare services through telehealth. So that is something that's kind of for ongoing research to look at that and to see maybe that is even playing a bigger role now, especially since it's become more available based on everything that has happened in the world in the past 5 years. And that does kind of lead to some future directions with this. So kind of what next? What can we look at? What can we learn? Or what do we still have to study? So I think exploring firearm suicides is kind of on the list to see if there's a different type of firearm suicide, if that's maybe diving a little deeper into what is the differences among these firearm suicides. Does it vary between rural and urban based on the type of firearm being used in these deaths? That is something to potentially explore, and that then can help inform policy on how to address that very controversial topic. And then, so also exploring social capital. So right now it's just one general variable, but maybe there are specific parts of it that are really beneficial. And it's also just because those opportunities exist doesn't mean that everybody engages with them. So how do we get people to engage with these opportunities to connect with one another and really build social capital within a community? So that's kind of future directions. And then also exploring method of suicide within some subgroups. So like a deeper dive among youth in rural areas. Do they kind of stick with is it still firearms or is it more the hanging suffocation? We saw that start to pop out in some of the analyses. So looking at that and looking at maybe men specifically across different methods versus women, like what are some of those differences? So just kind of exploring, there's lots of opportunities that can come out of this. And of course, this data did end in 2019. So even just accounting for the changes that have happened since this data, like what else is happening in rural communities that is contributing to these high suicide rates that haven't really changed or subsided even across the past 5 years since this data basically ended. So that's basically all I had. I did want to mention, of course, collaborators who were part of my AFSP project on this. And then I just have this thank you slide and questions. This is my email contact. If anybody does have questions after this, feel free to reach out and connect with me in that manner.
Hello, so I will be reading the questions from the Q&A. If anyone has more questions, pop them in and we'll answer as we go. Anonymous asks, how fascinating that suicide rates are higher when folks have more access to internet. Thoughts about what contributed to this increased risk? Doom scrolling?
Right. So it is kind of like that was kind of a something that's difficult to understand because it's basically the lowest and the highest availability of internet connection within people's homes that were related to, yeah, it's basically only those middle categories were decreased risk. So it wasn't necessarily increased risk. It wasn't really that different. And I do think it has to do with something like that, like access to this information, where it's like if you don't have it, if it's less available, well, then that's like a negative thing because you don't have access to information, you don't have access to telehealth or other opportunities. But then those communities that have it, and it's basically everywhere, maybe there is an inundation of too much information, or maybe some of the negative things that come with social media are more common or more available in that community. That is something that, I don't have an exact answer for it, but it is potentially it is an interesting finding that I think we can explore more to see what really is it about this internet access, and is there more to it within the community. So
All right, our next handful of questions are from Mike, who is one of our board members who does presentations throughout the state. So hi, Mike. Question number one, it looks like having low social capital in a community increases the suicide risk if looking at that variable independently rather than compared to high social capital communities. Is that right? If so, can you describe what it looks like to have a low social capital community slash county?
yeah, so I think I'm explaining. I'll try to kind of clarify, and hopefully I understand this. Like in all of our models, basically I had to have a comparison group. So it is always compared to like that lower social capital, or the high compared to the low. Um, and if I were to flip it, yes, the low social capital would have high. I'm not sure exactly how I presented it. Let me just, I'm gonna, before I just fumble through this, let me just see if I can find that slide, some of those slides. Um, but a low social capital community is someplace where there's not a lot of opportunity to engage within the community. So there aren't opportunities for recreation. There aren't really opportunities to join a business organization or civic engagement. So there aren't any regular clubs meeting. There aren't places for kids to go hang out. Like the bowling alley is like the kind of the old school um, view of that. There aren't really recreational leagues or gyms. There aren't business organizations or political groups within that community. So those are your low social capital. And those are the areas that are, yeah, potentially at increased risk of suicide, particularly compared to your higher social capital communities where you have a lot of opportunity to engage. So hopefully that answers that question.
All right. From what you have learned in your research, what do you believe are some of the most important protective factors that rural communities could work to create in order to reduce suicide risk?
Sure. So I think this is one of them, this idea of social capital. I think again, I think it needs further explanation or an exploration to see like what really is it about social capital, and then how do we engage people. But it is like a matter of like building connections with people and connecting people with similar interests so that they recognize that they're not alone and that there are opportunities to seek help. I think that is probably one of the biggest ways that that these rural communities could benefit and could improve. Like that's something that can be changed and can be increased to help engage people within the community.
Okay. Um, did you break out the 25 to 64 age group into smaller age ranges? Were there any different results if you looked at 25 to 35 versus 45 to 55, for example?
So I have not done that, but that is like a good potential or something that could be done in the future. And I imagine some of there, I imagine there would be some differences, especially maybe that some of the younger age groups that might fit more with towards the younger, like the young 10 to 24. I haven't done that, but it is something that I think my sample size is large enough that I probably could break it down a little further and look into that.
Wonderful. Does anyone else have a question to pop in the chat? Um, Dr. Steele-Smith, thank you so much for your time and for sharing your work with us. We truly appreciate it. We will be posting this webinar to our YouTube channel so that if you want to share it with anyone, you can. Please fill out the evaluation QR code because it'll help us plan our fall Research Connection program. Oh, I've got a private message. We will read that in a second. Maybe Luma can address that. But thank you, Dr. Steele-Smith. We truly appreciate your time and your work. And thank you for joining us today.